Appreciate you. So we will be discussing today rapid rule protocols for chest pain in the emergency department. I know this is kind of a specific emergency medicine one, but we see chest pain every day in most specialties. So I think it'll be very versatile to talk about today. But we'll be talking about the Heart Score, EDAX, and ADAPT. They're all screening tools that we use. So just the outline of today's discussion, we're going to be talking about just the importance of this topic. We're going to be comparing the different risk stratification scores, just some critiques, and a journal that kind of encompasses a couple other aspects of low risk chest pain. And then we'll be discussing a sample patient that I made up, and then any discussion and questions. So just to begin with our patient today, we have Mr. Davis. He's a 42-year-old male. He has well-controlled hypertension on lisinopril. He does not have any diabetes mellitus type 2, smoking, family history of coronary artery disease, and he's coming today with some chest pain. He reports a 2-hour history of intermittent sharp chest pain and discomfort when he was sitting at his desk at work. The pain is localized to the left anterior chest, and it worsens when he moves and he takes a big deep breath in. It doesn't radiate anywhere. He denies it being worse when he gets up and moves. He denies any shortness of breath, any nausea, diaphoresis, or any syncopal episodes during this time. And this is his first time ever experiencing any pain like this. Your review of systems was negative for any cough, fever, leg swelling, or hemoptysis. Your physical exam is pretty normal. His heart rate is 78, blood pressure is 128/78. His respiratory rate's 14, SpO2 is 99, and his temperature is 39.6. I meant to say 36.6, not 39. It's a fever. But generally, he's just comfortable. He's not in acute distress. Your heart exam is normal, rate and rhythm, no murmurs that you can appreciate. Your lung exam is clear to auscultation bilaterally. And then when you touch his chest wall, it's tender over the costochondral junctions on the left side of him. He denies he doesn't have any swelling on your exam as well, no JVD. Some diagnostics that you run, you get an EKG and it's normal sinus rhythm with no ST changes or ischemic findings. His serial troponins are negative at 0 and 2 hours, and his chest X-ray is normal. So we'll revisit him at the end of this discussion. But just the importance of this topic, chest pain is the second most common chief complaint that brings patients to the hospital in the United States, with the most common being abdominal pain. And though this complaint accounts for 5% of hospital visits, only 5% of these 5% are a true acute life-threatening condition, most common being ACS. It's estimated to be around $10 billion spent annually on chest pain workups. And though obviously true acute MIs are, if they're missed, the adverse events can obviously be very catastrophic for the patient. There's just a low prevalence of them. The clinical practice guidelines exist that can aid us as we evaluate these patients with low risk chest pain. But specific practice is going to be different between providers, departments, what have you, and even in different countries as well. It's largely different depending on resources being the most common cause of discrepancies between emergency departments. Recurrent ED visits for chest pain are common, with up to 40% of patients returning to the emergency department for chest pain within a single year. This is due to a variety of factors, which includes multiple etiologies that are evolving in the patient. It also includes fluctuating symptom qualities that they have and psychosocial factors without progression of any underlying disease that they may have as well. So traditional workup I've been able to experience too has been when we get a patient with chest pain, you get an EKG on them, some serial troponins, other labs, imaging and observation and admission, depending on what you find. And then obviously any other workup if they have other symptoms associated with this chest pain that may help you aid your diagnosis if it's not chest, like an MI that's causing it or ACS. With low-risk patients, admission and resources can be quite intensive if a patient doesn't really need them. And that's why they created these risk stratification tools to make sure that we're not utilizing resources that should be better saved for other patients. So to discuss first is the heart pathway. It includes the heart score within it, and it's used in the emergency department to identify patients with acute chest pain, so that they can be discharged earlier and by predicting the likelihood of an ACS event happening. As you can see here, HEART stands for the acronyms that make up the score itself. So it includes history. If you're suspicious of the patient at all, that's a little bit subjective. You have your EKG, age, risk factors, and then initial troponin. The risk factors include hypertension, hypercholesterolemia, BMI, diabetes, what have you. And then each of these components are scored on 0, 1, or 2. Depending on the score, I'll show you in a second, it'll put them into a low, moderate, and high category. If a patient is in the low risk category, then you can consider other causes for their chest pain. And like I said earlier, this will warrant how you take care of them in the ED with diagnostic testing and whatnot. And then lastly, when you discharge them, make sure that they have a good outpatient follow-up to make sure you investigate thoroughly what they've been going through that doesn't necessarily warrant being in the emergency department. So the scores, the low risk category is going to be 0 to 3. MACE stands for major adverse cardiovascular event that happens in the first 30 days after the patient is discharged. And so if they're in the low risk, their risk of this is anywhere from 0.9 to 1.7%. Moderate score is going to be 4 to 6 points. And the risk rises to 12 to 16%. And then a high score definitely needs to have a thorough cardiac workup because their risk of MACE is 50 to 65%. And then to compare it to the EDAX score. So the EDAX stands for Emergency Department Assessment of Chest Pain Score. It's safe, again, it's similar to HEART, and so it safely categorizes patients into low risk category and moderate and higher. However, this one was made in Australia and New Zealand, and it identified higher proportions of patients at low risk for MACE versus the HEART score. It had over 99% sensitivity in its original study, but as we'll discuss later, this was not the case in the United States. It does not include an EKG or biomarkers, and they have an extended version of the EDAX score that includes this to have a thorough risk assessment. And you can see on the side, it includes age, sex, diaphoresis, being present, and then descriptors of the pain that they're experiencing with their chest pain, which is interesting, I thought, to me, with negative points being associated with pain occurring upon palpation, or if it's worsening during inspiration for the patient. If the EDAX score is less than 16 and the EKG shows no ischemia, that's the low risk cohort that you're going to have and negative tropes. And then if they're above 16, they're automatically they're not low risk, and they should get a thorough ischemic and heart workup. Other chest pain causes should be looked into if the patient is at low risk. And then finally, the ADAPT score. The ADAPT score can also be used to evaluate patients with chest pain. However, it only identified about 20% of patients who are low risk, and so this is about half compared to EDAX and HEART. And it's to be used in conjunction with TROPES, EKG, and TIMI risk scores. The low risk category is going to be 0 to 0.3 risk percent of MACE in 30 days. So you can see the low risk category has a substantially lower risk of a MACE occurring versus the HEART score. Immediate risk, you'll have 0.8% chance of MACE in 30 days, and high risk, you got to follow your standard chest pain diagnostic pathways. The adaptive note, it uses troponin, ischemic changes on EKG, and then age, coronary artery disease risk factors, aspirin use, and severe angina, which I thought was interesting too. And then of note, the TIMI and GRACE scores, these are a little bit different. I've seen them occasionally be used. The TIMI score is used to risk stratify patients with presumed ischemic chest pain, but it's for patients to confirm if they have unstable angina or an NSTEMI versus like risk stratification. So this is if you're highly suspicious of an ACS event or something going on. And then the GRACE score is a mortality risk score. You know that they have a STEMI or unstable angina or an NSTEMI, and you're seeing what their mortality risk is at 6 months out. So just to put everything together, the clinical significance with these, the heart score is simple, it's quick, and it's the most commonly used in the United States. It has those 5 simple things, a part of the score. All of them use serial troponins. The safe discharge for like the lowest category is about 30 to 40% of patients, and their 30-day MACE risk is less than 2%. EDAX, of note, like I was saying, when the original study was recreated in the US, it only identified 88.2% of patients with MACE versus the a complete 99% was found with a heart score clinical study. So that's why we use EDAX in the US, or not as much in the US. It's mostly used in Australia and New Zealand, where the original study was produced with patients. But for the original study, it safely discharged 40 to 50% of patients with a 30-day MACE risk of less than 1%. And then ADAPT, the biggest change was just about half is safely discharged versus the heart score. So it's a little bit more efficient with identifying low-risk patients, the heart score versus the ADAPT. And then I found this interesting article. It talks about guidelines for patients with low-risk chest pain in the emergency department. This study, it was conducted in 2019. It looked for articles that reported patient-important outcomes, including a 30-day MACE, if the patient needed PCI, CABG, or they had resulted in death after coming to the emergency department with chest pain. And so the data was extracted from a bunch of studies that they had identified, end up including 41 studies that they found. So definitely something that could use more thorough investigation in the future. But some of the questions, this doesn't include everything, but some of the questions that they wanted to kind of, for practitioners in this setting to keep in mind for their patients that are coming in with recurring visits of this chest pain is, did we miss a diagnosis the last time that they were there? Does this evaluation now require more thorough evaluation, even though they're coming in with a similar scores and things like that in presentation? If the patient's already receiving the most thorough evaluation the last time they were here, what does this visit necessarily warrant? And how long that prior evaluation is good, valid, and valid before we repeat certain diagnostic testing. So they came up with recommendations. Of note, the recommendations that they had, it was very low or low evidence for. They just wanted to highlight that these areas would benefit from more robust prospective investigation in these populations. But just to cover the recommendations that they had gone through, these are all going to be for adults with recurrent low-risk chest pain. If a patient comes in with chest pain longer than 3 hours, they suggest a high sensitivity troponin. And then if that's negative, then they can be excluded for ACS within 30 days. It's reasonable to exclude ACS. A normal stress test, if it was done within 12 months for a patient who is presenting with low-risk chest pain, they don't recommend repeating stress testing. It doesn't decrease rates of MACE that they found in the studies that they had analyzed. If a patient comes with chest pain, there was not enough evidence to offer recommendations on when to admit a patient versus discharge, and that's going to be really to the physician's discrepancy. And I hate that answer. It's like, it just like the depends answer, but it really does depend on your patient. If they're right at that threshold and you're just suspecting something that would benefit from an inpatient stay, then that's obviously a good use of resources for a patient. If a patient comes in with low-risk chest pain and they don't have occlusive coronary artery disease, or they have non-obstructed coronary artery disease, meaning less than 50% stenosis, that was found on prior angiography within 5 years, then these patients their assessment can be expedited to outpatient referral. Um, that's what they found could be recommended versus admission to the hospital. And then if a patient had come in for low risk chest pain, prior CCTA within 2 years without coronary stenosis, no further diagnostic testing outside of the troponin was warranted at that time. And then just of note too, with these low risk chest pain patients, depression and anxiety screening they offered would be beneficial for these patients. And if we do a thorough tools with these and referrals and making sure they follow up on, we can't necessarily do that as an emergency department physician, but trying to set them up for the best success when referring them to these services, it may impact how often they come to the emergency department with a better understanding of what warrants coming and what have you. Obviously, some limitations. The heart score is not perfect. The EKGs and troponins are evolving over time. The high sensitivity troponins are very helpful and stuff compared to what I've seen like a decade ago. Troponins have come a long way just with the sensitivity of the testing that we have now. Thresholds for low risk is going to vary depending on location. Like the studies shown, patients in the US are different than patients in New Zealand and Australia. So it's just something to keep in mind too when we're assessing these patients. And then, as always, we're physicians and it takes a long time, well, we're going to be physicians and it takes a long time to get that clinical judgment that every physician that I've interacted with has. And at the end of the day, chest pain workup is going to require you to have some good clinical judgment. And then again, just touching on facilities differ, countries differ, regions differ. So just make sure you know your hospital protocols and how your patients are different than the population next door. So some just take-home messages for this discussion is these rapid rule-out protocols are very helpful in helping us safely discharge low-risk chest pain patients, working to help better allocate our resources in emergency departments. The heart pathway, including the heart score, is most widely used here in the United States. But that being said, you can definitely use EDAX and ADAPT as a part of your assessment because they're validated alternatives. So it is warranted to, if you want to add a little bit more depth to your assessment, 100% add those in. And then clinical judgment and follow-up will always be part of proper management for your patients. So back to our patient. If you put him into the heart score calculator, I found his history be a little moderately suspicious because it was happening at rest. And then he had a risk factor of hypertension, but it was well controlled on lisinopril. So I just gave him a heart score of 2. So Mr. Davis is a great example of a low risk chest pain patient, and he would benefit from having an outpatient follow up within a week with his primary care provider to work up why he had this chest pain, what is he experiencing, and hopefully add some resolve to what he was experiencing. I know I talked fast, so I apologize, but any questions?
So just to clarify, we don't really know what he has, or he still needs to be worked up.
Yeah, so he'd be like a patient that's going to do workup in an outpatient setting. It's a lot more, it's just better for the patient cost-wise. If you're just going to look at it like fiscally, patients are charged way more in the hospital for doing things like stress testing and whatnot. If that was warranted or other things because he is stable, it doesn't warrant emergency workup.
Okay. Just another question. When we first read his story, what popped up to me with my limited knowledge, I thought of pericarditis. Is there any?
And that could be used, and that's why we have like the other labs. We could check like white count and like sed rate, things like that, to see if he's like in an inflamed state or something. And then chest imaging too. His chest imaging was negative. But because he's stable, they could do something outpatient, I guess. But with the other things that being ruled out, I I would think maybe it wouldn't be that, but I don't know. Holly, do you have any? What would you do?
Sure. Obviously, all these scenarios aren't the same as actually seeing a patient in the real world because you can't ask follow-up questions. Like with pericarditis, often you find that patient feels better when they lean forward a little more. So they don't usually experience the pain when they're sitting up. They usually experience it actually when they're lying down. You also would ask these history questions of like any recent viral illness is usually the most common cause, or do you have any like underlying inflammatory conditions, any recent changes to your medications, like things that would, it's really rare to just see like spontaneous pericarditis. If we do a really good heart exam with pericarditis, sometimes you can hear like a little scratchy sound where the inflammation of the pericardium is actually like rubbing against the myocardium as it moves. And if you're a skilled ultrasounder, you can actually catch pericarditis on ultrasound exam at bedside, which, as we know, is pretty much free and painless and super fast. So it's a great technique for ruling in, ruling out these things. With a patient like this, there's a lot of gestalt involved. Like you want to lay eyes on the patient, and like BMI is only useful in the extremes, but you kind of want to ask them questions about like, are you sedentary? Obviously, you're working a desk job, but like, are you running 6 miles before work every day? What's your diet like? Just kind of getting a feel for, is this a healthy individual? Like, are they a type 2 diabetic because they're barely 6.1 on their A1C and they take metformin and that controls it? Or are they a type 2 diabetic whose A1C is like 13 and they're doing a bunch of insulin at the age of 45? Those kind of things kind of give you different pictures. And that kind of leads you to thinking more towards like, did you pop a little bleb? Like, were you a really tall, skinny guy who could have like easily been a spontaneous pneumothorax guy 10 years ago, and now you still have some remaining blebs left behind, which are really painful when they pop. Also, just on physical exam, when I press, does that make it worse? In that case, it's not your heart. It's going to be musculoskeletal. So all good things to think about. Hard to say just from a little textbook paragraph whether or not what this was. It didn't sound ACSE to me immediately, but great use of the heart score to rule them out. Heart score is really great for younger physicians who are a little more anxious about, ooh, am I going to miss something? Am I going to send someone home to die? That's something that's always really scary to think about. And heart score can kind of back you up and being like, oh no, I'm right. He's probably fine.
Thank you for your answer.
Is this something that you use, Holly, at all in your practice?
The heart score kind of lives in the back of your head if you're in the ED.
Yeah.
This is the GRACE 1 guidelines, and there's other more useful GRACE guidelines. The GRACE committee is delightful, and the GRACE 3 guidelines are a particular favorite because it helps you distinguish different types of vertigo in the ED, like malignant versus non-malignant. The GRACE 1 guidelines are pretty much never used because, as you kind of briefly touched on, the evidence for all the GRACE 1 guidelines is garbage. They have no validation, there's practically no research studies, and it's totally understandable because no one wants to do a study of, well, let's randomly send half of these people home and see if they just die.
Right.
Yeah, it's one of those, it's like cancer
Right.
in kids. You're not going to get a ton of numbers on it. We're going to have to figure out a different way to get validation over time. Heart score just lives rent free in your brain. Same like Curb 65. A good attending will not ask you like, what's his heart score? They're just going to be like, what are you feeling like risk wise? And your brain automatically is like, oh, it's like a heart score. It's like, he's low or medium or whatever.
Okay.
And that just kind of informs what you do anyways. If you've already gone ahead and gotten an EKG and tropes and everything, you've already like done most of the rule out work. You're not going to have someone having a STEMI or an NSTEMI or any kind of ACS really who doesn't at least have some elevated tropes. You can also throw a BNP in there if this is more like a heart failure picture or even a hypertrophic cardiomyopathy. And again, bedside ultrasound, just take a peek at that squeeze. If the heart's squeezing good and their tropes are low, your odds of this being something acute and terrifying and serious are pretty darn low.
Did anyone else have any other questions? Here are my references, and I just want to thank you. Thank you so much, Holly, for coming. It's great to see you again.
Absolutely. Also, going to throw out there, remember that literally half of our population is female, and on average, females do not present with ACS symptoms that we consider classic. More often, they're going to show up complaining of symptoms that sound like textbook heartburn, nausea, vomiting. Sometimes it's just, I'm feeling short of breath and fatigued. They're not typically, on average, describing that elephant sitting on my chest symptom. That is very much a classic old white man symptom of having ACS. And as a result, a lot of these scores are also only more validated towards that classic textbook, especially that gestalt portion, that what's your clinical history suspicion. You're like, well, she's throwing up, so that's not very suspicious. You got to remember to untrain your brain from the little inherent misogyny of old time medicine.
Yeah, I did notice that too, like when they were saying like limitations, like just the patient populations that they use for these risk stratification tools in their original studies were definitely leaning towards that. So 100%. Yeah. Well, again, thank you so much for taking your time out and waking up early for for us and all that. Thank you.
No worries. I'm not that bad of a person. I'm on night shifts right now, y'all.
Yeah, yeah, yes. Some context. Yeah. Thank you. I hope you have a good rest of your day, Holly.
Oh, you're super kind. Thanks,
Thank you,
guys. If you
Holly.
guys have any questions or need help with residency apps, I'm on admissions board at University of Utah, Dartmouth, where I did my master's of public health, and now at Mercy St. V's here in Toledo, which honestly, I was my top pick, and I'm super happy to be here. Like, send me questions. Miranda can give you my email or my phone number. I don't care. Shoot me a text. I'm happy to point you all to resources for all of the nonsense of navigating residency apps and how to have a happier life in residency. You don't need to be miserable.
I love that. Thank you.
We appreciate you. Thank you.
Thank you.
Yes.
Bye.
Have a great day. I'm just trying to stop the recording. Sorry, folks. Yeah.